Hello, my name is Ewan Soubutts. Thank you for your interest in our paper, The Shifting Sands of Labour, Changes in Shared Care Work with a Smart Home Health System. I want to talk a bit about what the shifting sands of labour means within the context of this work, and also what the findings of this study, which centre on physical and emotional labour in the home, mean for HCI researchers and practitioners who are doing work on work and labour around complex digital systems more generally. Before beginning this presentation in full, I would like to acknowledge my own positionality within this work as a younger, white, cisgendered male researcher, which, as we acknowledge in this paper, affects our understanding of our participants' worlds as they are older adults themselves. But first, let's pose a question. How can we use digital technologies to reduce the shared care burden in people's households? Posing this question has helped us as researchers to approach our understanding of how the complex smart home health system that we deployed across 5 households in Bristol in the UK was used, shared, and collaboratively constructed with others living in the same space. This study builds directly on our existing understandings of work and of physical, mental, and emotional labour by exploring shared occurrences of this type of work around caregiving practices in the home. This work also builds on literature looking at gendered roles in the home that come into play when delivering care, and also smart device ecosystems that centre on delivering care in the home by considering how this applies to a single older person and also their close care networks. Additionally, what separates this study from other work on smart home systems in particular is our focus on how the multi-resident household structure affects the adoption and acceptance of the smart home health system as a tool to provide care collaboratively. We define the multi-resident home where an older person is living in the same residence as at least one other permanent resident, who is either providing care support or social support for that person. Sometimes these residents are of different generations. For example, the grandchild of an older adult may also live in with the older relative in order to support their care at home for some of the time, or even to look after them full-time. We chose to work with a research group when conducting this study, who make and deploy bespoke smart home technology specifically for individual older adults. We chose this group as they were able to provide the greatest range of sensors that formed part of a whole system, which also included the voice assistant described within the paper. Altogether, the arrangement of devices that comprised this system provided the broadest range of technology that seemed most suitable for a 3-month deployment study. It was our intention to capture as broad a range of participants and households for this study as possible. We aim to include diversity as part of this study, but as discussed in the limitations section of this paper, this proved more difficult in reality for deployment studies of this type than is often anticipated. As such, we acknowledge how older adult households of higher income and primarily white middle-class participants were taking part in this study. People found out about this study through the local authority in Bristol in the UK, and people signed up after completing an online consenting process. Once the data was collected, a reflexive thematic analysis process was followed in order to code the data, and this was iterated upon by all authors on the study in order to reach the final themes that we provide in this paper. In total, there were 3 stages to our semi-structured interview process. The first, the pre-installation phase, sought to capture the existing lived experiences in each household. This was beneficial in order to inform the latter interviews as well, and provided us with much needed context to follow up with during the second and third interviews. After the first interview, participants were onboarded by the research group who supplied the technology for us. Following this, participants were spoken to again by the research team during the second interviews, or the so-called out-of-boxing phase. And then participants were spoken to about the system again for a third interview at the 3-month stage, once they had been using the system for that period of time. We'll go into each of these stages in a bit more detail in a moment. During the first pre-installation interview, participants told us about their existing experiences using their own technology, both low-tech and digital, that they owned within their own homes. Residents also shared stories with us about how they cared for one another, both using this technology and when going about their everyday activities of daily living. They told us about the strengths and challenges of using these devices, as well as some of the more pressing difficulties they'd experienced, including issues related to different devices' accessibility as well. The out-of-box interviews were the first time that we were able to speak to our participants after they had received the smart home health system. At this stage, we were able to discuss the setup process that was unique to each household, how participants had found the technology during their initial onboarding experiences, and how the setup of the system itself was in comparison to their earlier expectations. We were also able to probe into how relatives, friends, and formal and informal caregivers had supported the system during the setup phase with them present. This stage also revealed tensions between participants' expectations and the reality of using the system and doing their own work at home, both individually and together, in order to derive any useful data from the system. At the 3-month interview stage, our participants had become well accustomed to the system, and our conversations centered around how the technology had become woven into the social fabric of people's homes. The smart home health system and its individual devices had emotional and social impact and presence in people's lives, and our conversations reflected this, with some disjointed expectations about the system between their initial interviews and this latter discussion. And, as mentioned here, all of our households described to us how, whilst they were willing to invest the time to make the system work for them, the resulting labour costs became too high for each household, and eventually all of our households abandoned the SHHS at the end. So what did our interviews tell us went wrong with the system? Well, most evidently, participants struggled to create and sustain a workable mental model of the system. Despite the onboarding phase, participants found that understanding the sensors as being interconnected as part of this wider whole of the system required too much mental labour in order to be able to understand. Participants also found benefits from the sensors by using them for reasons other than their intended purpose. For example, in Household 5, the sensor-enabled mug was appropriated, or dumbed down, and used as a regular mug instead, as participants found that it kept drinks warmer for longer. The wearable wrist sensor was also used as a watch to keep the time, as opposed to using it for its fullest functionality of heart rate monitoring. This showed us that whilst the system as a whole may have been too complex to have lasting benefit, the devices themselves carried individual benefits for people through their simpler affordances and easier to understand interactions. So eventually, because the cost of understanding and using the system was too high, all of our households abandoned use of the system. Some did this after the study was completed, they told us, so that they could complete the study for us. But the reasons for abandonment were varied. For one thing, the system was cognitively demanding. The mental work required in understanding what the system's icons meant on the wristwatch, for example, to what the voice assistant was trying to tell them, and what the data on the dashboard actually meant was extremely challenging to understand. Others described investment of physical energy, for example, from placing motion sensors on doors and getting the digital dashboard to work on personal devices. But also, our interview showed that the emotional cost of using this system and its sensors was particularly high, and that there were disparities in people's expectations from what the system had advertised to them in the beginning. This was costly to enthusiasm and trust in the system, as participants expected that this system would help them out more directly with managing their health. So they discussed how they wanted the system to be more proactive in translating the complex sensor data and giving that information to them in a digestible format. Participants also wanted the voice assistant to provide this information to them as an actor. The system therefore did not reduce worry for caregivers that their loved ones would be looked after, and instead there was a large amount of disappointment that the system did not fulfill these initial expectations, which resulted in a high emotional labour cost towards the end of the study. So what would we recommend that smart home health system designers bear in mind when developing health systems for older adults to use in the future? Well, we would advocate not dumping large amounts of information on people up front, especially during what is expected to be an easy-to-understand onboarding phase. Further, there needs to be more sequential support for people throughout the process of adoption, especially in the very early stages where mental models of the system are still forming. We advocate reducing technical labour and reducing interactions to simple, easily afforded engagements where people can remember and understand how to access the sensors and their own personal data. Lastly, to support caregivers and system owners, there's a need to account for the diversity of experiences that people face when using systems, such as the smart home health system, and to provide clear but more tailored documentation that can be accessed by caregivers or care recipients who may interpret and use the system's data differently. Overall, we see that the shifting sands of labour involve great physical, mental and emotional costs in time, effort, enthusiasm, disappointment and labour. However, despite these struggles, there are reassurances in our discussions with our participants that there is benefit for smart home devices that afford simple, easy-to-understand interactions that positively reinforce engagements with people. Thank you so much for listening, and please do come to our presentation in Hamburg at CHI 2023 if you would like to ask more questions about this work. If you would like to get in touch before then, please feel free to do so by any of the channels shown here.